I was just saying a very warm welcome to everyone, and in particular to our governor colleagues who've joined us, Judith, Ruth, Ludford and John Bolt. And I know you've all said hello. I thought you were saying hello to me, but there we go. So you're very welcome. We might also have members of the public on the call either now or later, who of course we won't see necessarily in quite the same way. But just to extend the invitation to all of those and indeed all of our governor colleagues, if you want to raise any issues, obviously this isn't a public meeting, but under the circumstances we'd be very grateful if you want us to submit them, and we will leave a bit of time at the end of the meeting to revisit any issues governor colleagues and members of the public may wish to raise on the back of any of the discussions they hear this morning. So a warm welcome. I'll just go to John. I don't believe we have any apologies, John.
No, I don't think so.
No, very good. In which case we'll go straight on to the register and declarations of interest. I'm going to assume they're as advised in the register unless anybody wishes to make any amendments or additions. And if you do, if you could indicate by raising your hand, please. No, very good. They're all in order. In which case we go straight to the board story. Christian, are you going to introduce this item?
Yes, I'm just going to give it sort of a very brief introduction. So this is actually in the wake of COVID. We just thought it'd be absolutely fitting to do a more positive and an upbeat sort of story, and showing sort of the initiative that we have here at Chesterfield. So I note that we've got Dr. David Sandler on the call. So I'm going to let David sort of introduce sort of the initiative that he's introduced. Not just here, but I won't steal his thunder. So over to you, David.
Okay. Right, thank you. Hello, my name is David Sandler and I look like this. And that's how I introduce myself to my patients at the moment in the COVID era. I'm David Sandler, one of the consultant cardiologists at the hospital, and I'm here today with my co-conspirators, Sarah Turner-Saint, Head of Communications, and Sarah Ward, Deputy Chief Nurse, to tell you about a little project that we're involved in. We're promoting the wearing of smiley photographs of ourselves on our uniforms. The idea came to me when I saw photographs of health professionals in their personal protective equipment posted on social media earlier in the year. And I thought they looked rather like stormtroopers from Star Wars. Even I looked scary when I looked in the mirror at myself and thought, that's what I have to do when I approach my patients.
Yeah, yes.
Now,
he said 2 weeks, but I think it's been 3 weeks.
Well, I saw Evie, we went round there.
John.
Hello. Somebody talking in the background?
Yes, so he's just gone on mute, I see, David.
John, mute your microphone, John. Right. So when any of us interact with patients wearing the masks and the personal protective equipment, we need them to be relaxed, to feel reassured, and the photo seems to work. It helps break the ice, it amuses them. Sometimes they make funny quips about the photograph, and it gets them on your side from the start. And it requires nothing more complicated than a nice photograph in a plastic holder. As well as improving my patient's experience, I found that lots of staff members were stopping me in the corridor, pointing to the badge and saying, that's a great idea. But at first, no one else was using it. Fortunately, I bumped into Sarah Ward one day in the corridor. She said she loved the idea and I challenged her to make it become a thing. She accepted the challenge, and in collaboration with Sarah Turner-Saint, they produced a template for the badge, which is freely available on the hospital's intranet site. They provided plastic holders with clips so they could be clipped to your uniform. And we created a hashtag and I look like this. And we're using that on social media, particularly Twitter and Facebook, to spread the word. And suddenly it's become a rather big thing, not just in Chesterfield. We've had photographs sent to us from staff members in hospitals in the north of Scotland and in Wales wearing our template of a badge on their uniforms because they also think it's a rather good idea. You can read about it, more about it, in the hospital's Facebook public page, and there are lots of staff photographs like these being sent to us of members of staff all over the trust and in all different departments, photographing and posting on Twitter that they've done this. And if you want to do a Google search, hashtag and I look like this, we come up with lots of photographs. And if you do a Twitter hashtag I look like this, you'll also find lots of information about it. It's a simple, inexpensive idea. We think it's making a big difference to patients and patient care, and we feel that it's got great potential. Thank you.
Well, the thanks are all from us to you, David. You know, it would have been great. It would have been so easy to have that idea and not do anything about it, particularly given all the other pressures that there are in the trust at the moment. But in terms of having a human, caring, compassionate face as best we can for patients at this time, it must make an enormous difference. So we're very proud of you and we're enormously grateful. Thank you.
Yes, well, thank you for that. But it's not just me, of course. It's everyone who participates in it. I can see Zoe Linton there, and she's got one. She was one of the first people to get one of these badges. And Sarah, yes, she's got it there. Sarah, and actually, I went big. I thought it needed to be promoted. So I got Tony to wear a badge in one of his circulars to us. And even last week, Angie has gone to wearing the badge as well. So thank you, everybody, for agreeing to participate. It makes a big difference. The most impressive photograph I got was from the intensive care unit, which was this. So somebody had gone to the trouble of making 50 or 60 badges for all the intensive care staff. And that's an example of one of the staff members, Nat, actually wearing her badge. And then now, well, I hope they're all wearing it. I have actually passed one or two people in the corridor wearing it, but I think it's catching on, and people who hear about it are thinking that it sounds like a good idea, and it's so simple and it's so inexpensive, and it makes a big difference to the patients.
Glorious. And I mean, we've thanked you for the initiative, but I have to also say a big thank you for getting our board meeting off to such a glorious start.
Oh, thank you.
Much of the day will be spent on the challenges posed by COVID, but it's delightful to hear about some simple innovation making a big difference. So thank you very much for your time and joining us this morning. We're very grateful. And a big thanks also to the two Sarahs and to Krishna for your important role in making all of this happen. So very well done.
And I'm going to have to leave you now because I've got to go back to wards and clinics. So good day. And remember, I look like this. And goodbye.
Take care. Goodbye, David. And thank you again. Really lovely. Great start to the meeting. And as you said in your introduction, Krishna, lovely to start with something so extremely upbeat at a time of such pressure and indeed challenge and difficulty and sadness for some families who are feeling COVID at first hand. So lovely to hear all the steps we're taking to make the care of patients as good as we possibly can in the circumstances. So thank you for choosing to share that with us. That brings us on, if we may please, to Angie's Chief Exec report.
Thanks, Helen. I'm going to struggle to follow that. John, did you just want to come in on something? I could just see your hand up.
Yes, I'm just going to flag up that the meeting's being recorded, just to make everybody aware of that. Thank you.
Thanks, John. And thank you again to David. It struck me the other day that just walking down the corridor, visitors actually really appreciate seeing your face and the smile that everybody misses. So would ask all my colleagues to promote that. I know Helen's having a photo done on Friday, so thank you for the support. And I'll try not to bring us down too quickly, but I just thought I'd draw a couple of things out of my report. Firstly, our current COVID position in the hospital, and then I just want to touch on MRAD and our digital work, and finally our strategy. So if I start with COVID, we've currently 52 COVID positive inpatients with us today, 14 of whom are in critical care. And to date, sadly, we have lost 189 patients from COVID. So our thoughts with their families. We've been discussing the impact on our workforce, clearly very challenging, a difficult time of year for everyone in the NHS, COVID adding to that. And just thoughts again and thanks to all our staff who are working extremely hard. Our workforce absence at the moment is around 7 to 8%, and around 3 to 4% of that due to COVID, whether that's symptomatic or isolating staff. So that clearly has an impact on our ability to staff our areas. And Berenice will touch later on our restoration and recovery work. But I did want to highlight on a positive the really good work that everyone's done to make sure as many of our services have kept going over recent weeks and months. And there's some really positive information you can see there from October on the work that we've done. Interesting to note the national announcement around more monies next year to continue to build on that work, and we'll need to work through what that looks like for us. And clearly this month and going into December and January is going to be really challenging, which I say Berenice will pick up on later. But positive as well in that we have got the lateral flow testing for all our staff now, and Zoe I'm sure will be able to answer any queries on that. It's been a huge logistics exercise in getting that up and running this week, so thank you to Zoe and team. And look forward to getting that testing rolled out for staff. And the other light at the end of our tunnel is around the vaccine. A huge amount of work being led across the Derbyshire system to make sure that vaccination plan is ready to go as soon as we get the supplies. So thank you again to all our staff who are supporting that. And Krishna, I'm sure will pick up any questions and queries on that. And another little celebration, although we're still pushing, is our flu vaccination rates for our staff. We're at 80% of our staff, which again, a huge testament to the effort of the team and our staff putting themselves forward for flu vaccine, and even more important that we do that early this year ahead of the COVID vaccination. So that was all I was going to say on COVID. Our planning continues to be nationally, we're at a level 4, so huge amount of work goes into making sure we're running the show 7 days a week. And just in case anyone had forgot, EU exit occurs shortly, and next week there will be a local cell set up to make sure that all things Brexit that we need to plan for are in place ready for 31st of December. In terms of MRAD, I just wanted to say a really big thank you to the team who a couple of weekends ago came in and made sure that we are now part of the East Midlands Radiology Network. Makes a huge difference to our patients and staff having access to their diagnostic tests in a digital way. One or two challenges and hiccups as ever with a rollout of such a programme, but the team working through that and thinking not only from a technology point of view, but a wider digital point of view. We had a really good session last board meeting facilitated by NHS providers on digital. And that's everything from the work we're doing across Joined Up Care Derbyshire around an integrated care record, how we think of as a board around digital first for everything we do for our patients, and lots of good work that we need to build on that we've learned through the pandemic, that we just need to think about going forward, how we sustain that in a digital environment. And that leads me lastly but not least to the work we're doing on our strategy. Some fabulous response. Thank you everyone, those who have responded to the vision, mission, success factors and values consultation. Tony and Sarah are killing me every time I promote it because there's ever more work to do as we get more responses, but some really fabulous engagement on that. And there's joint work that we're discussing now around some of our services that Tony and Hal working with our Derby colleagues, for example, on how we can build our clinical strategy going forward, and that will be coming back to board in the new year for some more discussion and work. So they were the areas. Sorry, that was quite a lengthy one today, Helen, but just I thought important to pull out those key areas. A busy time for everyone. Thank you.
Much appreciated. Thank you, Angie. I'd appreciate if you could raise your hand if anybody would like to raise anything in respect of the items Angie's mentioned, or indeed anything else in the report. Jeremy, please.
Yeah, thank you. Thank you very much, Angie, for that, and for the written report, which is very useful. Just a couple of comments, really. One is, presumably the introduction of regular testing of staff is going to highlight some otherwise unknown asymptomatic carriers of the virus, and so we're likely to see a small uptick in the number of staff absences as a consequence. I'm just observing that. I'm sure you're, and I see Krishna nodding her head, I'm sure you're well aware of that, but it's in the short term, it's going to introduce some additional challenges. It's not to say it's not the right thing to do. Of course, it is the right thing to do. I just observe that in passing. The other comment is about the strategy. As I understand it, what has been consulted on is simply that one-page summary document. Is that right? Okay.
To date, yes. Yeah.
Today, okay. Very much looking forward to seeing a more substantial document behind it, which I'm sure is in preparation. That's all.
Thank you, Jeremy. We'll be seeing the fuller document. Is it next meeting or the one after, Angie? I can't quite recall what we agreed.
We're aiming for next meeting, certainly to have a draft for next meetings and then build on that to get final one further down the line.
Very good.
Great, thank you.
The idea is that it will all then coincide in terms of us having signed off the fuller document in time for the beginning of the next financial year, Jeremy. So that's the plan. Zoe, please. And Jeremy, please may you put your hand down.
Thanks, Helen. Just to Jeremy's first comment, to agree that yes, we are expecting a sort of short-term increase in absence. The pilot sites, the numbers are relatively low in the scheme of things, and also obviously part of the thinking is to identify and nip the problem in the bud around asymptomatic members of staff. So then it prevents outbreaks, for example, where potentially larger groups of people and larger areas are impacted. So it's that kind of shorter-term impact for that longer-term gain, really.
Thank you, Zoe. Very good. Well, thanks for the report, Angie. It was it covered some really important ground in a very clear way, so we're grateful for that. We're going to move on to the next section, which is about good governance, and we're going to look at the board assurance framework. I know Angie wants to say a few introductory remarks to set the scene, and then just to put committee chairs on notice, we're going to go around for a brief update from committee chairs in respect of any issues in terms of arising from your committee meetings that need escalation to board, and in particular any issues in the integrated performance report that you feel need consideration at board. So we'll do that in a moment after we hear from Angie.
Thank you, Helen, and thank you to colleagues who've worked with me on the BAF Task and Finish group. We've been looking at the framework, and also in the context of the last conversation around our new strategy, updating the strategic risks to bring draft back to board again in the new year. Apologies, I was aiming to have it for this side of Christmas, but things have overtaken us. But just to ask colleagues to bear with us while we pull that together and bring a draft format back in the new year. And I think I'm handing over to Jeremy now. Is that right, Helen?
Good. Thank you, Jeremy.
Okay. Thank you, and thanks to Gillian for preparing our new format report. So just 2 or 3 things I'd like to highlight from the People Committee meeting, which now seems like a while ago. It was in October. First thing to say, which is really important, is that we did note on the date that we'd been successful in winning the Healthcare People Management Association Excellent in Employee Engagement Award. So congratulations again to Zoe and the team for that. I think it happened since our last board meeting, and I think it'd be appropriate to just recognise that here as a great achievement for that team. In terms of the written report in front of you, just one minor correction I've noticed needed. Under the BAF 4.1, the committee action, it refers to suite feedback to committee regarding the impact of COVID-19 on student placement. The issue was the impact on universities at the time. You recall this was at the beginning of the university term, and COVID was ripping around a lot of universities. So the worry was that because students were being impacted in universities, it would impact in turn on their training with us. We looked at the education annual report. I know in the past this has been made available to board members. If you've got it's well worth a lot of really good stuff going on the education side, and I'm sure it can be made available to those of you who are not on the People Committee. The other point to note is we are recommending that the risk rating for BAF 4.1 should be reduced because we thought the likelihood score should be reduced from 3 to 2, so the overall risk rating should come down to 8 from 12. But otherwise, the report is as read, and I'm happy to take any questions.
Thank you very much, Jeremy. We'll take the questions at the end if we may, and I'll go to Mike next to hear both from the perspective of the Audit and Risk Committee, please, Mike, and your Oversight Committee.
Yeah, sure, no worries. Thanks, Helen. Well, the Audit and Risk Committee met on the 13th of October. You've got the report in front of you. I think the key thing I'd like to just bring to the board's attention, but it's in hand, is that we felt that there was a bit of a deterioration in the internal audit action follow-up. Now, that's completely understandable given what's going on in the hospital, and clearly from a common sense perspective, the Audit Committee were very happy to cut the guys some slack, and with Angie and Lee's support, particularly, we'll continue to move that forward. So no great shakes, but there was a little bit of a dip pointed out by our colleagues at 360, and the guys are all over it like a rash. So nothing really to concern there. Everything else was okay. As Angie's mentioned, we talked about the BAF Task and Finish Group meeting again, and we have meeting again, and we will continue to develop that, as Angie said a moment ago. Other than that, fairly anodyne, really. We did our review constructed by 360 on feedback, which went very well. So the committee self-effectiveness review worked, and it was a pleasing process to go through from my personal point of view, that it seems to be working okay. So I took some comfort from that I don't get fired just yet. In terms of the Oversight Committee, that was, again, fairly straightforward. What struck me there was particularly the compliments from Tony and the Exec colleagues that DSFS are providing an excellent service in these difficult times. We always knew it was going to be, two parts of the same team, and we don't really want to go down a them and us route. And clearly my biggest worry whenever I sort of chair one of these meetings was, do I get any sense of there being any division between the trust and the subsidiary? And I'm pleased to report to the board that there absolutely isn't at any level. I speak with Dennis for a half an hour at least most weeks, and he's very positive, very supportive, and he's acutely aware of his responsibilities towards the trust. I've always got an open door and an ear for Tony and Lee to make sure that those guys are getting support. With Berenice's appointment, I hope she's happy with the service getting. I know she and Dennis have met, as have Krishna and Dennis, and I'm pleased to report that it's going very well from a perspective of both the trust and the subsidiary. I keep threatening to jump on one of the directors' meetings with Dennis, but my struggle is to try and maintain independence. So in the short term, I'll just keep my weekly call with Dennis going to make sure that if there's anything that needs to be raised, it's raised. I spoke with him briefly about the two issues that came out of the governor's meeting around lighting and wheelchairs, and I've had a full response, which I think has been circulated, but if not, I'll circulate that around the board. But other than that, the report is as written.
Thank you very much, Mike. Very helpful. Jane, please, for quality assurance.
Thank you, Helen. So the committee met on the 9th of November. There are a few matters that I just want to raise. So the first is that board are aware that we've been keeping a close eye on outcomes for our patients following stroke, and we awarded some money for the development of a HASU unit. We received a report on the governance processes around the escalation of stroke and how we have moved that issue through the various committees, and also how that's connected to information that flows to our colleagues in the CCG. So a joint report has been produced just reviewing those processes, and I'm pleased to report that was a very good report, and actually showed that the committee were assured on the clear flow of information between the committees. So that's both within the trust and also out to the CCG as well. That report has an action plan with it, and there was an action related to QAC on that plan. which was actually about making sure that we're doing deep dives and also thinking about where key reviews are received. Now, both of those matters are within our terms of reference, and both of those matters do already happen, but we have agreed that we will have a review that included as part of the review at the end of the meeting. So we will, in effect, look at what needs to be escalated, what deep dives need to be undertaken, what key reviews need to be received in future meetings. So we will just make that more overt. Subsequent to the meeting, we've also had further meetings as an ed group about progress on stroke improvement. The second thing that I wanted to bring to your attention was the matter of maternity clinical negligence scheme. So board are required to sign this off. I think it's at the May board meeting. And just wanted to put you on notice that we've escalated this from QAC to your attention today, because the key lines of inquiry, of which there are innumerable, sit within 10 basic criteria, and those criteria we have to show evidence against. So in terms of our compliance, it's a work in progress. The elements have been changed this year, and also there's been a pause in respect of COVID. So it was just to say that further work's required on that, and that a report will come to board in due course, and that the risk around that is most certainly not around patient safety, but could potentially be a small financial risk to the trust as well. So that was the matter for escalating. I know that I'm going to bring Krishna in on that. I know that she's also had further discussions on that through Maternity Transformation Board, and I know in fact that we're not the only trust that are actually having difficulty in meeting those standards. So I think it's important to know that the criteria have changed and there has been a pause for COVID, but we are working on that. And before I bring Krishna in, I'll just finish the report and then I'll go back, Krishna, if that's okay. I just wanted to mention a couple of other things that don't have a narrative actually against them on the report. One was Falls update, and that was just to say that we invited the Falls practitioner to come and speak to the meeting, which was a really positive presentation. And that's on the back of the work on Falls being a sequin for last year, and us extending that work and making that that post permanent. So really pleased to have that presentation to the meeting. And also Dr. Roger Stark came to talk to us about the new medical examiner role, and again very pleased to note that the trust made excellent progress in establishing that role. And before I leave off, I wanted to say about silver accreditation. We have very, very good news in terms of our ACE scheme, so our care accreditation scheme. We've had our first unit that's reached the silver level, and that's congratulations to surgical assessment unit. So again, very, very positive. So if, with your permission, Helen, I'd just like to pass to Krishna on the matter of CNST, because I know that she wants to make a comment on it.
Please.
Thank you, Helen and Jane. Yes, it was just in support of what Jane was saying. We're just awaiting sort of a national sort of announcement around CNST. So just to put in context of what Jane was saying, we're not going to be achieving sort of 10 out of 10, but we're absolutely in with everybody else because of the pause, because of some of the requirements are about training and multi-professional training. We're not able to do that at this moment in time due to COVID restrictions. So they're going to be making a national announcement. We're expecting that within the next couple of weeks, which will be in support of what we're actually saying as an organisation as well. But we've been very sort of open and transparent about where we are and the actions that we're taking, and we feel really assured with the care unit itself and with the division taking that responsibility forward, that regardless of whether there is a national pause or not, these safety actions are absolutely the right thing for our women and babies, and we'll be continuing with the really good work that we've started already. So it's just a continuation of that, but just to put in context.
Very important. Thanks, Krishna. Alison, please, Finance and Performance Committee. Alison, you might be on mute.
I am, sorry about that. So at this time of year, Finance Performance Committee meets more often than over the summer in anticipation of providing assurance on performance under the most pressured time for the hospital over the winter, but also monitoring finances to financial year end and signing off financial plans and operating plans for the next year. So there's one written report within the papers, but we also had a meeting on Friday, which I'll give a verbal update to. So just flicking across to the papers. So the integrated performance report, we considered the report at the October meeting. We noted some variance on performance in duty of candour, and therefore asked Jane, as chair of QAC, to quality and assurance, to take a look at that. I'm pleased to report that the figures for that were presented on Friday show a degree of improvement. So, but Jane is going to do a deep dive on that. So, so IPR has been reviewed. The next section, which is restoration and recovery, winter planning, is really all together in the previous month and this month, which is the delicate balance between trying to keep elective services going whilst we're trying to cope with COVID. And we've reviewed all of the plans which have been very kindly prepared, and absolutely give assurance and support to the Exec for the very difficult situation we find ourselves in, and the challenging decisions that need to be made to flex resources, be that estates, staffing, and care. So want to report that we've reviewed those plans and we're happy with them. The other things that we've been taking a look at, the improvement report, improvements continue to be managed within the organisation, and that continues to support the performance that we're seeing. In October, we also did a deep dive on pathway improvement, and again, very pleased with that. From a financial point of view, we're reviewing year-end performance, and we find ourselves in very interesting financial times, but are confident that everything that can be done is being done to land our finances in the right place for Chesterfield, but also in the broader Joined Up Care Derbyshire community. We've taken review of two potential decisions, one about procurement of a building, one about progressing the urgent care village, where we've scrutinised both decisions and information presented. And we've also taken a look at the improvement plans for the emergency department. So, so lots of different things going on, but in terms of performance, I'd like to provide assurance that those plans have been reviewed and support the executives in what their decision making. And from a financial point of view, it's been a strange financial year and will be a strange financial year next year. But again, support all the work that's been done with Lee and across Joined Up Care Derbyshire. I don't know if there are any particular questions.
Thank you very much for that, Alison, and also for trailing the committee's scrutiny of two matters we would consider in private as a board for reasons of commercial confidentiality in respect of capital items at RPC and in respect to the urgent care village. But I think it's great as a matter of public record that the committee scrutiny of those in advance is noted. So thank you very much for that. Now, Jane, your hand was up a minute ago, but it went back down. Were you wanting to come in?
It was just to say that we have already looked at duty of candour and identified the steps that needed to be taken, and as Alison said, performance has absolutely improved, and likewise we have recovered all the performance on complaints as well.
Very good. And just to ask you to look at the question from Judith in the chat box. We'll come back to that at the end of the meeting as we promised we would, but just so that you're aware of it, Jane. Beverly, please.
Apologies, I'm having IT issues today. No question, Helen. Excellent summary as always from all the chairs. Just a comment. Great work from Gillian on the summary sheets. That's really helpful when we're reviewing papers before board. Just one constructive comment on the left-hand side where there's an item with no commentary under actions. I think it would just help with clarity if it said no action required, because otherwise there's almost an inference it's not been discussed.
Thank you, Beverly. I'm sure colleagues will take that forward.
Yes,
Thank you very much. Yep, very good. In which case, I think we just need to check that there's nobody else who wants to come in on those that important suite of papers, including our opportunity to scrutinise the IPR. Tony.
Helen, I'd just like to reiterate the achievement of Surgical Assessment Unit, because actually operationally that only came into being last December. So it's exceptional, the progress that they've made. So I just wanted the board to be aware of it. They've only been in existence for a year.
And our COVID response would have been so much harder without having had that way of working and the resilience it's brought to our operations. So that's thanks and appreciation due and now recorded. So thank you, Tony. I'm going to move us on then, if I may, please, to our engagement and involvement section. And the first item under that is the Freedom to Speak Up biannual report. I'm sure Abby will have joined the meeting. I just check. Are you on the call, Abby?
Hello, I am.
Very good. You're very welcome, Abby. Angela, was there anything you wanted to say by way of introduction?
No, just to highlight and thank Board for their support in continuing to promote freedom to speak up. It may seem obvious, but in current climate, then even more important that we continue to support that work. And just to thank Abby for her work and then ask her to draw attention to the key areas in the report for us. Thanks, Abby. Thanks, Helen.
Thank you, Angie. So as you can see from the data, the cases are continuing to increase in line with other organisations, which is really positive because it shows that there's an increasing awareness in our speaking up, about speaking up in our organisation, and also an increase in workers feeling safe to do so. Some learning for me during this time period has been that staff members are feeling increasingly empowered to speak up directly to their managers. And I'm hearing positive outcomes from this where people have felt listened to and have felt supported by managers and leaders. I think this demonstrates the process of speaking up is starting to become more embedded in our organisation, and that leaders are demonstrating listening, and there's been clear action, and they've been providing feedback both to myself when I approach them and to workers when they approach them directly. I have recognised that as a trust, we need to approach it trust-wide to fully embed our positive speaking up culture with managers and leaders. The National Guardian's Office have recently, I think it was in October, they introduced some core training for all workers, which I'm working with Zoe and Maxine Simmons to start rolling out in the best way that we can work that out for. They are going to be introducing some training specifically for managers and leaders next year, but rather than waiting for that, we've started to design my own training session for managers and leaders, which I'm hoping to get into essential training for managers and also leadership assembly, which I believe the next one is in a few weeks' time. I've also been speaking to our organisational development lead about bringing speaking up into one of the modules on leading the Chesterfield way. So we're hoping to do that fairly soon as well. And then just another example of working collaboratively to have a far-reaching impact on our workforce has been through the development of our BAME network support group. So I had several Freedom to Speak Up contacts made to me from BAME colleagues about issues that were affecting them and the need to provide more support to the wider people in the organisation became clear. So I fed this initially through obviously shared it with Angie and with Zoe, and I fed this through the Be Yourself group as well, and worked with them and the lead for organisational development to identify trust-wide whether a separate BAME group was required. So we did a trust-wide survey and it was established that this was wanted. So since then, we've created a BAME support group for our colleagues and we've brought them together. It provides them with another safe space to speak up and to be heard, and members of the group have also since shared personal experiences to facilitate learning at Leadership Assembly. So for my next report I will look at collating some of the themes of things which need to be done or which are being done trust-wide as well. So I would like to ask for continued support from the board, and also to ask you if there's anything more you think I could be doing to improve our speaking up culture. Thank you very much, Helen.
Thank you very much, Abby. It's a super report, gives us great assurance about the process, and reflects very well, Abby, on your outreach in terms of the level of interest and traffic you're getting. And that's a great testament not only to your diligence, but to the style and manner in which you're going about the role, and the trust and confidence people have in you and speaking up. So I think you know, if you're with us, we'd be asking you to take a bow, but you might have to take a virtual one. So I'm sure there will be thoughts and comments on this. Who'd like to lead off? Sue, please.
Thanks, Helen. Just to say thank you, Abby. It's a really clear paper, well set out, a joy to read, and the results look really positive. So well done, and keep up the good work. It's brilliant stuff.
Thank you.
Zoe.
Thanks, Helen. Just to add what's already been said, really, Abby, and to make the point that you've been really visible. So even during COVID times, you've sort of done that in an appropriate and a safe way, but you've been very mindful of still going out and about and going to areas and being there for people, so people don't always have to seek you out. Just think, oh, I've got a problem, I'll go find Abby. It's more, I don't know, like doing a listening session or that kind of thing, where people can just drop by and see you, which I think is really, really helpful. So thank you for that.
Thank you.
Berenice.
Thanks very much, Abby. It is a really good report, and it's really positive outcomes. I just wanted to kind of reiterate, I'm lucky enough to be going through a bit of an induction at the moment and getting out and listening to a lot of people. And one of the areas that they do pick up on, and they absolutely understand how to access, is freedom to speak up. So you're clearly getting the message out there, which is really important. Thanks very much.
Thank you.
Beverly.
Thank you, Helen. It's really in the report, but it's just to assure the board that the resource of the Freedom Speak Up Garden is constantly under review from myself and Angie, because Abby is one person for 4,200 staff, and whilst we've increased her hours, it's still quite a big ask. So there's a lot of work being done by Abby to build up the team of champions around the trust. So that work's ongoing. And I suppose just an observation that Angie and I have the opportunity to look at cases in depth, and it's just getting that balance, that retaining confidentiality but assuring the board of whether there's any systemic issues in the trust. So maybe we can think about that together with Abby, and whether there's more information we can impart to the board.
Thank you very much for that, Beverly. I'd really not to detract in any way, shape or form what's already going on, but I think the next step for us is to be able to be assured as a board that there's nothing that's coming up through the Freedom to Speak Up process that requires an organisation-wide response to a systemic issue, recognising that will need to be reflected on carefully and handled with thought and discretion. For all the issues of confidentiality we've discussed, and in no way, shape or form would we wish to compromise that. But I think it will be a kind of the next step in taking our good practice forward. So we'll leave that with you, Abby, to have some thoughts about how that might be best achieved. And thank you very much for all it is you've done in such a magnificent manner.
Thank you.
Very good. So I'm going to move us on now to the next item on the agenda, which is the staff and patient experience report. And we've got Krishna or Zoe, or perhaps a duet, to introduce this.
I'm going to start, Helen, Zoe, then I'll hand over to Krishna, and then I suggest if we want to go around the virtual room to give a bit of an exec sponsor update as usual. And I know as part of that, Angie wants to talk a little bit about staff mentorship. So perhaps we include Angie as we go around the room.
Okay.
Yeah.
Very
okay.
good.
So from a staff experience point of view, our current position on the National Staff Survey as of last Friday, so the 20th of November, the response rate is 51%. We use Quality Health, as the board will perhaps remember, the highest acute trust at the same time was 55, so marginally higher, and the average was 42. So whilst we're quite a way lower than we were last year, we are kind of higher than the average around the patch. Talking to colleagues, I think our experience is typical of other places. We're taking a considered approach to encouraging participation this year, recognising the pressures and what's happening, and also that there's lots of different opportunities for people to be listened to outside of the survey as well. So we're being quite, I think, measured and I feel appropriate in terms of how we're doing that. We've got about just short of a week to go now before it closes, and then as usual the results will be early in the new year. The difference this year are the 2 COVID questions, so that's another reason we're encouraging people to participate, because there is the opportunity to say that. I know a lot of people say, I've already talked to lots of people about my COVID experience, I don't necessarily want to fill in a survey, but yeah, so that's where we are with that. And the other thing that I wanted to highlight was our national recognition around flexible working, which I know is something as a board we committed to a few years ago now, and really had that commitment from a board level to be different, basically, to sort of change our culture around flexible working. So, and we've seen the results of that through our staff survey in the last few years. When you look at the graph, it's a pleasing upward trend, which is nice to see. So we were contacted by NHS employers in light of that to talk to us about what we've done, so we can share some of the good stuff we've done with other people. So, and the links in the paper. Just before I hand over to Krishna to highlight as well, the last conversation we had at board was about metrics, and including something around metrics as well as the narrative around the priority team areas. So Krishna and I have talked about this, and we felt we would do, from a staff experience point of view, choose different metrics depending what's happening at that time. So for this month's report, it's around appraisal season, because the season finished at the end of October, so that was timely. From a trust perspective, we achieved 92.1% for our appraisals, which I think is fantastic given the circumstances of the year that people have had. I think that's a real positive sign of leadership. And from a patient point of view, it's the friends and family test data, which we think will be consistent throughout the reports, because that's quite rich. So I will hand over to Krishna.
Thank you, Zoe. So just wanted to draw your attention to sort of the patient experience. This is like friends and family. We've not had any national benchmarking data. We are anticipating something out in December, but we're not entirely sure. But we've continued to sort of report our internal data. In some of the areas, it's not quite where we want to be, and there may be reasons for that, such as outpatients. Because of the wording of the questions, it potentially relates to visiting, or lack of, so from our patient's point of view, relates to lack of face-to-face, and it's about the interpretation. So we've had some negative feedback in some cases around waiting times. What we've identified, it's about being very specific with people. So if we're saying it's an 11 o'clock appointment, then, and it may not be, then widen that out and let people know that it'll be a time frame of an appointment. So we're already working with those improvements and taking sort of our patient feedback sort of very seriously. In patients, it links back again to lack of visiting. Because of where we are with COVID, we've obviously restricted our visiting for very good reason. But we're actually supporting and we're getting we've had feedback as well from a number of people about use of iPads, how beneficial it's been. We've had some patient sort of meetings and family meetings about, and some of the feedback that we've had is how positive it's been, actually being able to have face-to-face contact through our FaceTime sort of medium on the wards, or staff phoning relatives to give them updates, and that's where we made a plea and a promise, and I've been around and checked. We've got it everywhere, that we've got outside all the bays and the wards, we've got where our patients are with communication. So if they're able to communicate themselves with their loved ones, that's brilliant. If they need our support, then something that's a bit more robust and sustainable for us to be able to support our patients, to be able to have that sort of interface with their family and friends, which is really important for their mental health and their rehabilitation, really. So it's really just to give a good idea. One of the things and the challenges is to how about getting that information timely. We have got an internal mechanism to pull off from our friends and family data very timely sort of verbatim comments, which is in the main very positive, which will be a boost to staff. But we're working with something that we're calling sort of our ACE boards, which is a series of information that we're wanting to put in boards at the front of the each of the ward, and friends and family will be very visible there, and that will be very transparent when we do have visitors, but patients and family will be able to tell sort of where we are in the metrics going forward. So that will be something that we'll be doing very timely. The main focus that we're having at the moment is to increase our response rates with friends and family, and we're having that as sort of a much more visible, and certainly coming through our Quality Assurance Committee, what our response rates are in each of those areas. The high, the number of the responses, and we can engage with our patients, then obviously that's where we can, richness of information that we can try and sort of improve and make those improvements that are necessary. I'll hand us back around to the exec sponsors now.
Are you going to pick one, Krishna?
Sorry,
Helen, you're muted.
Yeah, thank you. Just before we do the tour of exec sponsors, it's very pleasing, Chris, to hear particularly about real-time information and about actually, Chris, I think you go on mute might help. Yeah, about real-time information. And I think there's a real desire, as we've said on a number of occasions in reviewing this report now, to bring some kind of technology, if not innovation, to bear on the whole collection, on increasing the sample size and improving the visibility. And I suppose mindful that we make that observation regularly on the back of this, thought it might be good if we captured that as a specific action. Perhaps on the back of today, and in light of what we know is the glint in your eye to move this agenda forward. So at the right time, when you feel in a position to bring that to board, but I do think it would be helpful if we caught it on our action tracker, the general approach as opposed to the specific report. So back to the tour now. Lee, why don't you kick off the tour? You get mentioned several times in dispatches in the report.
Certainly, in terms of my role on Durham Ward, I'm meeting with them on a roughly monthly basis. The main topic of conversation is their participation in NHS E&I's Acute Frailty Network, which is a sort of improvement initiative around how do we ensure and triage our frail elderly patients most rapidly into that frail elderly environment. So that's very positive and exciting. Just the challenges they face around, particularly at the moment, about isolated and sometimes stranded patients not getting out to the right location once they've got into the acute context. And the exciting bit for me for this work is, because of my role in the system space, I'm linking that acute frailty network work into the work going on in the system in Aging Well, which is a big initiative about the role for GPs, the PCNs specifically, and the community trust, and linking these things together. So I genuinely think that's quite exciting around how our frailty service might be able to reach out and in. The specific challenge at the moment is, have we got the capacity to do a little bit more spotting some of our frail elderly patients earlier when they come into the emergency department, which is difficult at the moment for sensible reason, and triaging them up to Durham. But it's a very humbling role at the moment in Durham, just the current climate for those patients, and quite how isolated they can be, both outside and then lamentably inside the organisation. So hopefully, though, with joining together that acute frailty network work and the Aging Well initiative, I'm quite positive that we might be able to do something quite exciting and groovy in this space, because the clinicians are getting quite keen on how we might be able to link those two things together. So I think that's my broad update on Durant. On RPC3, or Ashgate as they should probably be known, a bit numeric description, RPC3, I'm going to see them tomorrow. I haven't seen them since the last update, mea culpa, but we're going to have a bit of a chat about landing the strategy and how are they feeling. They were a lot more positive the last time I met. There was perhaps a little bit of an accusation that we spent a lot of energy getting them here, but perhaps not quite the same amount of energy landing them well on arrival. But that had sorted itself out quite a lot the last time I met. The next conversation we're having about is just the primary care strategy and their role in it, as well as more globally how primary care is responding to the pandemic. Just to note, Kate Chilton, who's the manager who came with us with the Ashgate practice, is going on secondment into the Hardwick place, which I think is very positive in terms of our reach into the sort of PCN and play space, but there's obviously a slight risk there about quite how well she knows Ash 8. So we need to make sure we manage that well. And finally, and sorry for the verbose update, decontamination unit, we've got a clearer handle on just deployment timescales, and there's been a joint briefing between Synergy and ourselves about what that's starting to look like, to hopefully persuade the staff that the people that will be managing from Synergy are some two-headed monsters. So we got some sensible folk up from Derby who run the decontamination service down there to just explain what that Synergy feel will look like, which I think was well received. And we've got some hardening but not quite finalised timescales for contract deployment and cheapy transfer.
You're getting some applause in the chat, and from me for managing to introduce the word groovy to the board meeting today. So well done, Lee. Who would you like to pass the baton to?
I'll pick the baton up, Helen.
Well done. Thanks, Tony.
I'll pick it up. So my area is ED department. So a lot of focus over the last month or so has been on the development of the new ED department and proposals and the learning from the COVID experience, and just revisiting, if you like, the patient pathways and the designs. That's resulted, as you mentioned earlier, in terms of paper to private board. So that's been really useful and engaging and very reflective for the teams. Equally, from a flow management point of view, and Berenice is continuing this, we've certainly got our plans in place that supports the ED department in making sure that there isn't any build-up of patients unnecessarily, and they flow well through the hospital, and in the system avoidance methods in terms of minimising the number of patients that turn up at ED. So that's worked well. And as my handover to Hal, I would also say both myself and Hal have been in conversation with the new clinical lead, Rashid Sahal, who's taken a much more broader approach to not just ED, but the whole care unit, and talking to staff at all levels, which is developing thoughts around the scope of the care unit, and for improvement plans going forward with various staff. And I think the whole experience of COVID has brought the team together, you know, in adversity to get over some of their issues as a team, not solving them all, but there's still much more work to do, but really good progress all round. So I'll hand over to Hal as that connectivity.
Thank you, Tony.
And just to make the connection, to mention that we have we're interviewing for 2 ED consultants in mid-December, which, considering the number of vacancies we've held for such a long time in ED, is really positive news, and both of those people are suitably qualified, and we're hopeful that we'll be able to recruit them. My 2 areas are outpatients and theatres. Outpatients, I've made several visits to several different outpatient areas, largely sort of hearing and trying to support around the challenges that bringing back in face-to-face conversations has been for them regarding social distancing and messaging to patients and carers about the number of people that are allowed in an outpatient clinic area at any one time, and the challenge and the unhappiness that can bring in certain circumstances. So they've had a, in some ways you would think that it all going virtual would have made their lives very easy, but actually it's almost the opposite from that point of view. So I've been trying to support them with that. As regards theatres, there's sort of 2 different stories in a way. There's the what's called PACU, so the post-anaesthetic care unit, is the very kind of unhappy area of theatres, and Abby, who was on earlier, will know that various people have raised concerns to her as Freedom to Speak Up Guardian. There's quite a dysfunctional team in there. They felt quite disengaged from the rest of the hospital, and it's then been exacerbated by the unit very much shutting down during the first wave and people being moved over to critical care to support that. So we've set up regular engagement meetings, because one of the issues was that they felt very disconnected from the rest of theatre and there wasn't regular communication with them. So we've set up regular meetings with the Donna and Steve, the matrons in theatres, are now meeting regularly and communicating, and hopefully we're going to start to make some progress, although once again, because of the second wave and lots of them being quite a change in their work, it's been a challenge for them the last few weeks. The other side of theatres, I'm sort of pleased to report, I think, is in a much better position than it was a couple of years ago. Many board members will remember that theatres was one of the difficult areas where there was a large cohort of people who were kind of unhappy and disengaged and so on. I had just last week, actually, I had an engagement session with about 10 staff members from theatres, a whole range of people, nurses, ODPs, HCAs and so on. And universally, they were all saying it was a much better place than it was a couple of years ago. They were really positive about the management that they'd had, particularly from the new matrons, Donna and Steve, but also from management and felt that there was much better engagement, felt they were being listened to. Some of their concerns about, simple things like how they were booking their annual leave, they felt had been listened to, and so they really did all say that it was much more positive than it had been. So I was really pleased to hear that. Not perfect, but much more positive. So there you go, ending on a positive note from me.
Thank you, Hal. They're the executive directors mentioned in the report, but I wouldn't wish to deprive either Berenice or Krishna of the opportunity to add anything, should you wish.
Am I all right to go, Helen?
Yes, certainly.
Thank you. So my two areas are Portland Ward and the Birth Centre, and we did do a board to ward visit in the Birth Centre, which was really positive. Very busy at the time, actually, from the day we went. And I've made a subsequent sort of a number of visits, and I visited yesterday. So one of the areas that links into some of the patient experience is there's a large sort of area that they use for the sort of the staff huddle, that there was a lot of people there and not actually in the rooms. And one of the reasons was that disconnect between some of our digital capability. So we've trialled a number of different options with having, so the wives are more engaged into the rooms sort of with the women, which is a real positive. So it's just early days. I went down yesterday just to see how it was going. Early days, we're just going to feed back, but we'll just see how that plays out with perhaps some of the patient feedback that we get from our mothers as well. So that has been really sort of well received actually by the staff themselves. My other ward is Portland Ward, which is not quite as I would like to portray it. So Portland Ward is a trauma orthopaedic ward, but actually it is near enough empty at this moment in time. And we made the decision, bearing in mind that we've got such an increase in our critical care capacity, to move the whole ward into critical care as our B nurses. So we've done focused training, support, education, working alongside, lots of buddying. Now I've been into the intensive care units to actually see, and instead of moving people on a shift by shift basis, taking this new way of managing a situation, the feedback from the staff has been really positive. They've all been in the same situation, so that it's an existing team able to support their existing team in difficult circumstances. I mean, we've had really positive sort of paying out sort of on the close Facebook as well about, don't be worried about coming out. I was there for the first few shifts. I was really well supported, and it's actually it's been far more positive than it maybe could have been. And actually, it's perhaps something that we may need to think of should we be in this situation again. I mean, we've said to Portland Ward sort of this will be for a number of weeks, because obviously we've got trauma cases that when the numbers increase, then the Portland staff will need to go back and support that specialty. But actually, over these last few weeks, I'm absolutely incredibly proud of the leadership team and all the people from that ward of what they've actually gone. They've put their anxieties to one side. They feel supported as an organisation. They've been really well received, really positive from critical care for receiving them as well. It's gone really well to date in very, very difficult and challenging circumstances.
Thank you, Krishna. Very helpful update. I'm going to go to Berenice and then Zoe and then Angie in that order.
Thanks, Helen. I haven't been allocated specific areas yet, but it's just to reassure that I have been down a number of times. I've been down to ITU and met with all the team to discuss some of the operational challenges, just listening to the staff, and as a result of what Krishna's just fed into to you all, has been some of the outcomes and some of the solutions that were been put in place. Been down to ED and listened to some of the staff around there. I suppose one of the areas that I'm definitely not linked into is that patient experience, except for the odd kind of query and complaint that comes through from patients directly to me. So I obviously need to pick up on that, Helen, and make sure that I have allocated areas and I'm able to get that patient experience as well. But I would agree with Krishna in the sense that the staff have done an absolute amazing job adapting just how much they have had to do.
Thanks, Berenice. Zoe.
Thanks, Helen. Berenice, in relation to your areas, because obviously it was a new role, different to Krishna, you've had a handover of teams in the same way that Krishna has had. Angie and I felt, as we normally refresh the list every year when we get the staff survey results, we thought it'd be appropriate to do it then, basically. So rather than this sort of later stage, let you do your general induction of kind of meeting people around and about, and then obviously all of us will get new teams, or we'll have a look at the list again when we get staff survey results. So that was our suggestion, if that's okay with you. So from my point of view, my two teams are Eastwood Stroke Unit and Murphy. So Eastwood, I've had lots of different conversations at different times with people, various leaders in the division, the care unit, and on the ward itself around some of the issues they've been having over the last couple of months. Jane referred to the in the QAC update to the stroke action plan. So issues around that and other things that have been happening, really to sort of offer support from an exec sponsor point of view, which is a slightly different perspective to that being kind of through an operational sort of chain of command point of view, so slightly different offer of support from that perspective. Also in Eastwood, the matron who was interim basis on there has now been substantively appointed, which from talking to different people has been really well received on the unit. So I think that will be a positive appointment as well, to have that stability as well. So that feels like a good appointment. And last time I was up there, I did do some rallying around the badges, the "and I look like this" badges. So next time again, I'm going to see if they have got around to taking the photos and printing them off. So that's Eastwood. Murphy, so Murphy are now Staveley on Staveley ward, but Murphy as was. So on my visits there, talking to people, it's really been drawing the difference between their COVID experience in wave 2 compared to wave 1. So board colleagues may remember in wave 1 they were a COVID ward, and this time around they're not. They're sort of back to dealing with more of their kind of core patients, I suppose. So they're having quite a different experience this time. We've had new members to the team, whether that's newly qualified, some of our international nurse colleagues, and they've also had other people volunteering to go work in other areas, including critical care. So quite a few different changes in the team there. So yes, it's felt just different for them, really. They have been keeping up with some of the informal team development stuff where they can. So you know, when it was allowed to do socially distanced dog walking, for example, those kind of things, which I think's been sort of good to see that they've managed to keep that going, and they're already thinking about Christmas and what they could do around Secret Santa and things like that. And from the patient point of view, they had their care accreditation process as it was at that time a few months ago now, and I know they've been quite proactively looking at that feedback and sort of different people taking responsibility for the different areas. So when they do have their ACE assessment, they'll hopefully be raring to go for that.
Thanks, Zoe. It's clear from the report how diligent you are about conducting this role, but when you describe it, it's also clear how enthusiastic you are about it. So thank you for that update. And last but by no means least, Angie.
Thanks, Helen. And I just wanted to feed back to board some discussions I've been having with Clive, my staff mentor. He has joined us today, but he's having technical problems with his audio. So unless that's miraculously fixed, he won't hear me, but I promise to feed back. And it was just a really interesting reflection from me when we were talking about some of the challenges around how we cascade the Leading the Chesterfield Way training, and quite rightly we do that as a a cascade, so without sounding too hierarchical, start at the top and work our way down through senior leaders, so that people lead by example, and we work through that. And an alternative way of thinking around that is to look at line managers who may be more junior in terms of their banding in the organisation, but actually have responsibility for a larger number of people than someone in a more senior band. And I've discussed this with Zoe and with Dennis, because Clive is obviously a DSFS member of staff, and some really positive response to how maybe we can think differently around delivering the organisation of that training, so we get the spread in a different way. Clearly reflecting that we've only got so much capacity, and there'll always be a staging to that. But I just thought it was worth feeding in some of those conversations that staff mentors make you think about things differently.
That's really good. Thank you for that. And I know we're extending that programme, so hopefully we'll be hearing further updates in due course. So thanks very much, Angie. Now, there have been great reports, and no apologies for the time it's taken. Beverly has been very patient, so I'm going to go to you first, Beverly, and then I'll come to Sue.
Thanks, Helen. Just to echo your comments, I think this is excellent work from the execs, and I'm sure it's really appreciated from the staff. Just some feedback, which is timely, Lee, if you're going to RPC Ashgate tomorrow. I see in the report their appraisal completion rate is only at 54%, in sharp contrast to the fantastic results everywhere else. Atul and I went on a virtual tour of RPC with Krishna, which was really well attended from RPC staff. And there's some really interesting feedback, and the common theme often with problems is poor communication. And a particular issue that was raised was around appraisals. And disappointingly, they viewed it with an element of suspicion, which is disappointing, because appraisals should be a great thing, you know, to highlight the good and make constructive comments about the future. And it might just be worth reviewing what we asked from them. Their perception was that it was a trust process that had been overlaid to RPC, and perhaps question just how relevant it was. So I just think it's really timely, Lee. Interesting for you to pick up on that tomorrow.
Thanks for that, Beverly. Timely. If I can go straight to Jeremy, please.
Okay, thank you. Thanks to exec colleagues for their reports. It's really helpful, and thanks for all the hard work they're doing. I just wanted to go back to the written report and make a comment about the FFT. I think it's not possible to interpret FFT scores unless we know what the response rates are. And I know I've raised this in the past, and I just reiterate a plea that every time we have an FFT score, we have a response rate to go with it. I understand that the response rates remain very low in some departments, and that being the case, then all it tells you is that the people who respond are not typical of the people who visit the department. So please, 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 in future, can we never see an FFT score without a response rate?
Krishna, I notice your hands up. I'm going to give you the last word, both to say whatever it is you want to say, but I'd be grateful in response to my earlier comments and Jeremy's comment just then, if you might conclude the item by giving us a summary of where you think it is we might take the whole learning from patient and associated feedback in the future.
Oh, a very large remit. Thank you, Helen. You're quite right, Jeremy, that we haven't been putting those response rates. We're putting them in so that we're just circulating a sort of a draft format for the new Quality Assurance Committee, and that will have response rates in. But you're quite right, it needs to be. I mean, our general response rates are about 15%. Nationally, we're trying to achieve sort of 35% response rates. I'd like to see that ambition higher than that. I think it's absolutely pivotal that we understand what our sort of customers are saying, and if it's only then that we can really listen to and hear what they're saying, and then be able to put some improvements in place. So it's absolutely pivotal that we have a higher response rate to go with it. So that's absolutely fine. it is more tricky because actually some of the feedback we get would be friends and family, and obviously we're limited currently with the family part of things with our lack of visiting. So I think that richness of information will be lacking for some time, because I think when you put sort of the patient themselves and the family feedback, of which we would necessarily at this moment in time only get that through complaints and occasionally compliments, it's that whole gambit. So I don't feel that we're going to be in a position until we have full visiting to get the wraparound and get the whole information and story. But it is about showing where we have learned, showing where we've done improvements, and sharing those improvements, cascading that through. And that's really the next step from the friends and family that I would like to sort of just add at the end.
Thank you very much.
Thank you.
Very helpful. So now I'm going to be all heart, and I'm going to suggest that we pause and have a cup of tea. And I hope that's a welcome suggestion. And if I could ask that we're back, it's 10 to 11. If I could ask that we're back for 11 o'clock, please. Refreshed and ready to go. See you all shortly. Welcome back. Hope everyone enjoyed that few moments to refresh. And it brings us on to now, please, the next item on the agenda, which is the green plan. So all yours, please, Lee.
Thank you, Helen. I think the summary on this paper is it's not quite perfect yet, but it's better than once it was. What's happened since the July board when we discussed this is the NHS has published nationally, it's delivering a net zero NHS document which clarifies what is the precise ambition for the English NHS in reducing its carbon footprint. For the reasons that we described in the July board, just around the NHS has an equivalent carbon footprint to the airline industry, this will be a growing and important agenda for the NHS about how we curtail our overall carbon footprint. In terms of the work that's been going on in the Trust since the July board, there have been 3 meetings, September, October, November, of the Environmental Strategy Group, which has now started to come up with a much more granular work plan in the main domains around where we can reduce our carbon footprint, which is shown in the appendix. I want to give my thanks to Steve Bacon, who's the Energy and Compliance Manager, Sally Ludditz, who's the Health and Safety and Environmental Advisor, Steve Wilson and his colleague Nicola Wood in Procurement, and Chris Tan, the Director of Infrastructure for DSFS, who are owning each of the silos of the work plan as we've constructed it. I think we're now in a position where we're pushing the Sustainable Development Unit on how do we assess the embedded carbon in the goods and services that we procure, which is the key next piece of work we need to do as a trust. But we've not managed to find anybody nationally who's done that yet. So I think with that introduction, Helen, around there's self-evidently a response now from the English NHS and a clarity of the targets. Hopefully there's a greater clarity around the work we need to do in the Trust. But I think there's an acknowledgement that this work programme is going to be rolling in nature and we're going to be restating in it each year. I think that's probably ample introduction to elicit comments from colleagues.
Thank you very much, Lee, and a big thank you to you and indeed to all of your colleagues who are being so proactive around this agenda. We've got a number of hands raised, but I will, as you will anticipate, need to go to Jeremy in the first case, given how ably he's championed this whole agenda.
Okay, thank you, Helen, and thank you, Lee, and thanks for this report. I agree it's an improvement on where we were, but you'd be surprised if I didn't have a number of criticisms and suggestions as to how it could improve further. I have to say, firstly, there are 1 or 2 bits in it which are a bit sloppily produced. So that, for example, in the first section, it refers to reduction in energy use and the amount of waste the Trust produces. But then if you read the actual data later on in the report, you realise that actually neither of those is true. Our energy consumption has gone up over the years, as has our waste production over the years. So there are things like that, and there are 1 or 2 places where it says kilotons when it should read megatons and so on, which I think is very unfortunate. And I worry that it implies a kind of lack of commitment to this agenda. But I think my main concern is that it's not smart enough. And by that, what I would like to see is something like the analysis which is contained in the model carbon emission footprint diagram, showing let's have a look at our total carbon emissions and see where the big numbers are, and then have smart plans to address those big numbers. And I absolutely appreciate that that's particularly difficult around the procurement, which is after all the biggest chunk, and it's really good to hear that we're working with the SDU on that, and that's obviously a big challenge. But you know, there are big numbers in there about the commission services and the gas and electricity, and I would just love to see a plan that says that over 5 years, these are the numbers we hope to, by which we hope to reduce our carbon emissions in each of these areas. And there are 1 or 2 emissions in that. So if you read the NHS Net Zero report, they highlight that 6% of the NHS's carbon emissions are due to food and catering. And on this table with our model number, it's just given as 0, which is clearly wrong. Now, 6% is not an insignificant amount, and I think we could be doing things like advocating a one day a week and increasing that over time, 1 day a week of having a meat-free offer of all our catering outlets, which would go a long way to, over time, reducing the amount of carbon dioxide we produce. So I think that's my main concern. I don't see this as being smart enough yet. And then my parting suggestion is that we put this on the risk register, because the climate crisis is a health crisis. You know, if we don't get this right collectively, globally, then COVID will seem as nothing, to be honest. It is a major risk for us collectively, and I think it should be on our risk register. I'd be happy to put some more observations about this in writing to you, Lee, which I'll do after the meeting. So those are my sort of immediate thoughts.
Thank you very much, Jeremy. Sue, please.
Thanks, Helen. Well, it's hard to follow that because I don't have anything like all those lovely stats and the deep scrutiny and expertise that Jeremy has. So I just wanted to give my view was I found the paper to be very encouraging, because I think we have, as you said, Lee, made some really good progress from where we were. And I think, you know, it's obviously a very complex subject, but I think the focus on that, the kind of 57% of the majority is a good thing to see. I appreciate Jeremy's point that there's lots of other stuff to go at, but that seemed very sensible to me. So I just wanted to say thanks, because I think in previous times when it's been to board, we've not given good feedback. So I wanted to at least acknowledge the progress. I think it's very positive. And I also think you might need to let me buy your light bulbs, because I'm sure I can get them cheaper than £500,000, but that's a slightly cheeky comment. But thank you, Lee, generally.
Alison, please.
Thanks, Helen. I suppose my comments summarise Lee's commentary around progression, Sue and Jeremy's. For me, in reading this report, the constant question I had was, are we moving far enough and fast enough? You know, to have horizons that are 2 years away on some things that feel quite simple just feels like we could be able to move further and faster. So that would be my request for a review of, can we get there faster than we're currently planning?
Thanks, Alison. Atul. You're on mute, Atul. We can't hear you, Atul. I can't see him on the list actually anymore. Wait, we just check that he's still with us. It looks like Atul has dropped. Oh no, he's there. Your hand was up, Atul. It's now down and you are on mute. But if you do want to come in, you're very welcome. We'll take that as a no. I'm assuming, Jeremy, that's an old hand. Okay, very good. Well, I think you've had a nice range of comments there, Lee, haven't you? You've had an acknowledgement from colleagues of the huge progress that's been made, and I'd like to echo that. It's impressive, and there's clearly some ambition and structure now being brought to bear on all of this. You've not surprisingly also heard some desire for smarter plan with smarter targets, clearer milestones, a testing of our ambition around pace and if it's sufficient or if there's more we could be doing. And I think Jeremy's helpful and sensible encouragement that we need to put this on the risk register. If we'd had coronavirus on our risk register 5 years ago, we might have been in a different place. And in terms of global threats, you know, this is of the same magnitude, if not greater. So I think it's sensible. We should keep an eye on it in the normal way of monitoring and managing our risks too. And you will, I hope, reiterate our thanks and appreciation to your colleagues for their contribution to all of this work too, I hope, Lee. I'm just checking the chat because I see another one. Lee, your hand's up. Feel free to come in.
And I think we're seeing this far more iteratively, Helen, and I hear the smartening up and I hear the pace issue. I think the change hump we've got to get over first is just the measurement of the procurement stuff. I think once we've done that, I think then when we're looking at the annual report, we'll have a platform for saying something far more positive around year-on-year carbon performance last year versus this year, which I think in and of itself will have some interesting results around big changes on travel, the consequential impact of the embedded carbon on the PPE we've used. So I think there'll be quite big changes year on there that then we can start to interpret in that, well, how much further can we go on energy reduction then once we've got that full carbon capture information? So I'll work with Jeremy, but I don't think this isn't the last we're going to hear about this for 3 years. I think when we're doing the carbon section of the annual report, we'll be saying something a bit more proactive and positive about where did we get with these actions, what's outstanding and why, and can we go faster? But I think we've got the platform to do that now.
Very good. That's really much appreciated. Thank you very much, Lee.